welcome. Thank you, Lori. We're recording this session and welcome to session 8 in our 2025 Medify webinar series. I'm pleased to be hosting and co-presenting tonight with Andrew McLeod and Anita Srivastava. I will start with our land acknowledgement. We acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. I am hosting from Toronto, and that's where Medify is located, on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Atawendurons. This is Dish with One Spoon Treaty Territory. I invite everyone to think about where they are joining us from. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors. We invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Some housekeeping. Please remember to share your comments and questions during the webinar by posting in the chat box, and choose the chat box that has everyone or attendees rather than just hosts and panelists. Towards the end of the session, you can raise your hand. So in about the last 30 minutes or so, and Lori can unmute you if you'd like to ask your question aloud. There will be a session evaluation at the end. Please do complete it. It's really important feedback for us. And just a note again, this session is accredited with the CFPC and the Royal College. And so Lori typically sends a notice of attendance at the end following the webinars. A big thank you to our webinar series committee members who have helped with all of our planning and often contributed to delivering the webinars. And stay tuned for November when we will be joined by Philip Dweck talking about infectious disease considerations, and December, care of the elderly, and a little pre-Christmas cheer, merry moderation event. So let me try to switch to the next slide deck. Great. Confirming that everyone can see that okay. We're good?
Yes, very good.
And fantastic. Oh, I didn't introduce our speakers.
Right.
I'm really, really honored to be joined by Andrew McLeod and Anita Srivastava. Andrew is a registered social worker and addictions counselor with lived experience, having accessed methadone and OAT for nearly 2 decades. Drawing from nearly 30 years of lived experience with substance use and recovery, Andrew combines personal insight with professional practice to bridge gaps between service providers and people who use drugs. He currently works as a community consultant with Medify and as an addictions counselor with Renaissance and Alpha House Recovery Community. His work focuses on reducing stigma, improving access to care, and fostering compassionate, evidence-informed approaches to treatment and recovery. Dr. Anita Srivastava is the Medical Director of Addiction Medicine at Unity Health Toronto, an Associate Professor in the Department of Community and Family Medicine at the University of Toronto, and a physician at Breakaway Community Services. In addition to a long career in practicing and teaching comprehensive family medicine in an academic family practice teaching unit, she has been instrumental in furthering the state of addiction medicine care. She was one of the founders of the Addiction Medicine Rapid Access Clinic model and received provincial grants to help expand RAM clinics across the province, where they are now a mainstay of addiction medicine treatment. She has authored research papers as well as clinical protocols and guidelines that have been adopted on a provincial and national level. So Andrew and Anita are co-authors on Medify's new guidance for methadone prescribing. We may have some other co-authors in the audience as well. I think people know who I am, Jennifer Wyman. I'm also an addiction medicine physician working at Women's College and working with Medify as clinical programs lead. So um, I know we have to do these disclosures. I can run through them, I think, on our behalf before handing over. Andrew and Anita received honoraria from Medify for work in developing the guidance being discussed. And as I've said, I received salary support from Medify for work in developing the guidance. We have no relationships with industry or pharma or conflicts to disclose. And just to note that this is the QR code links to the full document. I'll put the link in the chat as well in a moment, or try. But it's an opportunity to acknowledge all of the contributors, the co-authors to this document. It was peer reviewed as well, and all of those reviewers are listed in the document as well. So this is really a group effort. And we hope tonight to talk about the overall framework of the guidance, which really involves trying to balance the risks around toxicity and tolerance, being on methadone, not being on methadone, and how to engage people beyond thinking just about doses as well. So, Andrew, I'm going to turn over to you.
Beautiful. Thank you very much, Dr. Wyman. I'm incredibly grateful to be here. It's always a pleasure. The first thing that I do want to touch on is this slide. Where are we? Just a second. I think we're.
I'm sorry.
No. That's quite fine. The first one that we've got talks about our background. Back one more, and here we are.
There we
So
go.
that's where. No, you're doing an awesome job. So the first thing we do want to talk about is just a little bit about why we did this. So as most of you know, the last guidelines that were written in 2011. They were rescinded back in 2021, and new guidelines were required for a couple of reasons. The first was based on the toxic drug supply that was out there. We were seeing huge, deaths that were coming out, as well as really low engagement and retention within the methadone program. That, in addition to a lot of new nurse practitioners and new people that were practicing in the field, what was necessary was to have this, a new set of guidelines. Now, we did this, and we in the slide previously we showed the people that were responsible for this. This is a consensus-based practice, which meant we met several times, having long-winded conversations and often going through things until we were in agreement. And we weren't always in agreement with things, and when we weren't able to find agreement with certain areas, that's clearly indicated in the document. You can move forward to the next slide if you'd like, Dr. Wyman. The next few slides that we're talking about here show a few things. This one here was written by one of the co-authors, Ashley, and it captures part of what really needed to be included here. I'm going to give everybody just a moment to read this quote. We titled this slide, "It's More Than the Dose." And I think that's important. Ashley and I have worked together on a couple of occasions. And the first thing that we wanted to capture when we were having this, and we included people with lived experience, was just the impact of what it's like for an individual who's receiving methadone and what it looks like. I myself, as Dr. Wyman had indicated, accessed methadone for nearly 2 decades. So that's nearly 2 years. And in that time, had some incredibly amazing experiences with physicians, and likewise had some horrific ones. What really came out through our conversations was the need for us to have relationships with our practitioners or with our clinics, where we could have trusting, understanding relationships. And Ashley captured this really, really well when she pointed out what it was like to have a relationship that didn't involve a power dynamic with their doctor. And I found for myself that when I came in and I was afraid of being honest with my physician, when I was unable to sit down and have an honest conversation about what my goals were, um, that I wasn't able to move forward. I went into clinics and had some, as I was saying, some pretty horrific experiences, and I talked about one of them recently. I uh, I had the chance to run into somebody that I had spent some time in their clinic years ago. It was well over 15 years ago now, and I would go into that clinic and I would sit for 6 to 7 hours waiting to see a doctor, only to meet with them for 90 seconds. That person didn't know my name. I went in there and they simply sat down, pulled open my chart, looked at me and said, "So no more changes then." And I would walk out the door with a prescription. It wasn't a relationship. I felt like I was a number for this person, and it was and I didn't feel that that person even understood me or knew what I was about. Um, Likewise, I had conversations with a physician where I would walk in and I would sit down, and they would look at me and talk to me like I was a person. That doctor sat across from me and sat with me and asked me and said, "Hey, Andrew, how are you doing? How's Madison? How's Jacob? Those are my kids." They asked me how things were going at home. They asked me how things were going with my health. And all of a sudden, in that brief 3 to 5 minute conversation, what happened is I started to feel like I was a person with that physician. Um, in this relationship that exists with a physician, you have this ability to engage and connect with patients. And I can only speak for myself, but I felt most of the time less than. I didn't feel good enough, and and to have that feeling uh, either perpetuated or to have that feeling changed is something that physicians have the ability to do. You can move forward. Thanks, Dr. Wyman. Uh, this OET should not be a full-time job, and it unfortunately is or at least it was for me. One of the things is that without OAT, and Ashley captured when she said nothing else is possible. We're talking about a life-saving medication. This program mitigates, ultimately, it mitigates death. And one of the things that came out in terms of our conversations were one, hours being convenient for people. That's to say, people are able to have drop in visits. Holistic care, meaning that somebody is able to um, receive care from the moment that they walk in until the moment that they leave, and that there's options for them. I was very rarely ever on time for my appointments. I was perpetually late for everything. And uh, to have a clinic say to you because you're 7 minutes late or 10 minutes late that you're not going to wait for 10 hours or 8 hours or 6 hours is ridiculous. Having somebody be able to utilize the wonderful technology that we've got is absolutely something that we came out with that said that that's something that should happen. You can move forward to the next slide. In terms of what the environment should look like, I had an opportunity while I was at CSAM to sit down with somebody who accessed the clinic that I used to access, and we both sat and talked about it for a little while. Um, the type of language that's used within the clinic, the clinic should be a safe place, and not realizing it while I was accessing the clinic, the language that was used by staff uh, affected how I felt about myself. I remember going in and wanting to see where I stood with having just done a urine screen. And I walked up and asked, can you just give me my results for my urine screen? And the staff member looked briefly at my chart and said, "Yeah, well, you're dirty this month or this week." I think I had done them, I was doing them biweekly at the time. And I don't think the staff member was intending to make me feel bad about myself. And truthfully, I don't think at the time that it would have affected me consciously, but utilizing language that's appropriate. That's to say, telling somebody that they're perhaps positive for cocaine or that you're positive for fentanyl, rather than saying to somebody that you're dirty. The other thing that came out is an environment where it's free from people that are selling drugs outside. I routinely would access a clinic that I would walk up to, and as I was walking in the door, there was somebody outside, and they would consistently ask me if I wanted to buy any oxy. Did I need anything? Instead, utilizing things like peer support. And for a lot of people that are accessing the clinic, it's the only opportunity they have or the only contact they have with medicals, with primary care. So understanding that and working with the physician to collaboratively come up with what your goals might be. For some people, they may be walking in uncertain of what their goals are. For other people, they're simply looking to have their dose of methadone act as in addition to their ongoing use. They may want to continue using, and other people may want to engage in an abstinence practice. And for a lot of people, this is a process. It was for me. So being able to have honest conversations with your physician. Go ahead, next slide. This here, I mean, something as small as offering somebody something to eat or a coffee or a drink. A lot of people come in to the clinic, and the things that a lot of us might take for granted. Um, it might be the only time that somebody has a warm cup of coffee or a warm cup of tea. Being able to offer cookies or something small might be helpful. Being treated like a human, I can't explain how important that was. As I said, in the times that I was treated poorly, uh, and there was many of them, I also was treated really, really well, and I was shown kindness at a time in my life when uh, that was rare. So, understanding that you got this opportunity to really impact somebody in a positive way, or to perpetuate the feelings that they've had for themselves for a long time. Um, Trying to figure out what it looks like for writing prescriptions, extending them, perhaps working with somebody who doesn't have identification, all sorts of things that came up that we had long discussions around is are factors that you should consider. I think that's my last one, Jennifer. Oh no, I've still got one more. I know we shuffled some of these around. Um, so what it looks like when somebody's moving between programs. So that might look like somebody being incarcerated. It might look like somebody leaving incarceration or custodial settings. Um, I routinely missed doses. I said that I was perpetually late. I was also perpetually absent from appointments as well as missing doses. And that shouldn't mean that somebody doesn't have the opportunity to continue a prescription. There's obviously guidelines that we need to follow, but understanding that we're working with somebody and this is a life saving medication. Um, when people don't have identification, working with them to see what that looks like. I routinely was had doses that were held, or I would be unable to start methadone because I hadn't gone and gotten necessary blood work. And the reason I hadn't gotten necessary blood work is because I didn't have a valid health card. And the reason I didn't have a valid health card is because I lost it. Routinely, I did this over and over and over again. I think at one point I had my physician issue me blood work 10, 15 times. And every time I'd come see them, I would shake my head and say, I lost it again. Not really feeling great about yourself. My physician looked at me and said, okay, well, let me print you another one. Is there anything that I can do to help? I mean, that's an opportunity where just through kindness, that person was able to make me feel a little bit better about myself. Um, Trying to understand what usual practices look like isn't the standard for a lot of people that are on this life-saving medication. And I think you can move forward. And back to you.
Okay. I'm going to do the next section. So we had a lot of back and forth and a lot of
animated discussions around what the starting dose should be, and looking at the evidence and experience with starting doses greater than 30 milligrams of methadone. For years, the standard starting dose was always 30 milligrams, but in the era of fentanyl and realizing that people needed higher doses, guidelines began to emerge, which had different higher dosing thresholds, as well as guidelines around adding long-acting morphine, slow release morphine on top of methadone. So in 2021, we wrote a guideline through Medify around methadone in the era of fentanyl. And in that, we recommended a starting dose of 30 milligrams, and that you could combine it with slow release morphine up to 300 milligrams. In 2023, BCCSU came out with a guideline saying that you could use an initial dose up to 40 milligrams for individuals who had very high tolerance using fentanyl and who had had previous experience with methadone. SAMHSA from the United States in 2024 came up with a guideline saying, which was pretty radical, saying day one, you could dose up to 50 milligrams based on an individualized assessment by an experienced individual. We looked at the evidence. There were 3 studies that we could find that used much higher doses, and we used some of these studies to base our recommendations from. Seeger 2024, this was a prospective study. The other 2 were retrospective cohorts. The first one, they did a dose of 40 milligrams on the first day. Day 2 was 60 milligrams. Day 3, 80 milligrams. And they then allowed for dose increases up to 20 milligrams every 3 days for people who were, and the people were largely people who were reporting daily fentanyl use. There were 93 people in the cohort. 65 of them actually were able to go right through that dosing protocol. The ones who didn't were because they missed appointments, and so they weren't actually able to do the increases, and so it took them longer. The 65 patients, or the 2/3, who were actually able to make it to the end of that dosing protocol ended up at a much higher average dose. They ended up at an average dose of 89 milligrams. And they had a treatment retention rate of basically 90% versus those who didn't make it through and took a little bit longer, and their average dose was 49 milligrams by the 2-week mark. There were no overdoses or adverse events reported. There were 2 retrospective studies done, 2018 and 2022, which also looked at higher doses. Stone 2018, 154 patients looked at 30 milligrams in day 1, but they then increased quickly, 10 milligrams daily for 2 days, and then every 7 days as required. And again, no adverse events, with just, I think, 2 patients dropped out. And then the final retrospective cohort, they allowed for higher increases, but they allowed up to 40 milligrams on day 1, up to 50 on day 2, and up to 60 on day 3, but they were individualized dosing, and it was a retrospective cohort and based on clinician experience and how the patient presented. And what they found was an average dose on day 1 of 28 milligrams, day 2, 37, and day 3, 42 milligrams. And also, again, no adverse events. And Jennifer's put in the chat, no reports of sedation, fatal or non-fatal overdoses. And as I said, 85% retention with Seeger for the 65 individuals who made it through, who did the higher dosing protocol. So these numbers are not huge, but they're definitely very promising. And the vast majority of patients in these studies were using fentanyl. They didn't have any real exclusion criteria. In the Seeger study, patients were young. The average age was 38, and they didn't exclude people for other substance use. About 13% were using benzodiazepines, and that's what was found on their urine drug screen. So they were perhaps a younger, healthier group, but they were regular fentanyl users. And again, no fatal or non-fatal overdoses, no sedation reported, and no adverse events. And really good treatment retention. Next slide. So the goal really is, how do you reach an effective dose in a manner that's timely, collaborative? You want to consider comfort, risk profile, the individual risk profile, and also you want to make sure that they're safe. So you want to consider things like opiate tolerance, the risk of toxicity, versus the risks of there not being on methadone at all, and your own experience in having done this before. Next.
So we divided it up into low tolerance, moderate tolerance, high tolerance, and very high tolerance, recognizing that a lot of this is a clinical judgment. Low tolerance, we described as, or we defined as using low potency opiates. Example, somebody's using codeine, or low doses of moderate potency opiates, such as like oxycodone, 20 to 40 a day, generally less than 100 milligrams of morphine equivalency. It could also include intermittent use of higher potency opiates. So somebody who maybe is smoking or injecting, but not as frequently or not daily. Moderate tolerance. So somebody who's using oral use of higher doses of moderate potency opiates, for example, oxycodone, 120 to 160 milligrams a day, hydromorphone, 32 to 64 milligrams a day. So generally around 100 to 300 milligrams of morphine equivalent. And recognizing that sometimes it can be hard to know, especially if someone is using street opiates and you're not exactly sure if someone says I'm using an OxyContin, exactly what it is. And it's usually somebody who's not regularly using fentanyl. Again, recognizing that sometimes people will come in and say that they're using Percocet, but really what it is, there's fentanyl as well. So it's also important to establish what actually is being used and how frequently. High tolerance, we defined as somebody who's using daily or near daily use of heroin or fentanyl, less than a gram a day, smoked or injected, regular injection use of morphine or hydromorphone, and somebody who's using high doses of moderate potency opiates taken orally, such as hydromorphone, 64 milligrams a day or more. Very high tolerance, we defined as, or we described, these are descriptors that could go in this category. Obviously, there could be many more. Daily use of fentanyl, a gram a day or more, smoked or injected. So this is really just sort of a framework in which you could kind of help assess, somebody low, moderate, high, or very high, recognizing that this isn't going to cover everybody, but it may kind of give you a general idea of how to determine tolerance. So the other part besides tolerance is the risk for toxicity considerations. So people who would be at high risk for toxicity, somebody with advanced age, those 3 studies they put up were generally younger. They didn't enroll people over the age of 65. The Steger study, the average age was 38. Somebody with advanced age who's frail, has significant alcohol or benzodiazepine use that's causing intoxication or sedation, somebody who's at risk of respiratory depression, such as somebody who's got advanced COPD, severe liver dysfunction, somebody who's recently started sedating medications, for example, antipsychotics or sedative hypnotics, and somebody who's had interruptions in their opiate use, maybe somebody who's been incarcerated or who's been traveling and has had interruptions in their opiate use, and so they've lost some tolerance. The other risk of toxicity, so somebody who's at risk of toxicity but not necessarily high is somebody who's using moderate alcohol or benzodiazepines. They're using medications that are sedating, but perhaps they've been on them for a while. They're not actually having any too many sedating effects from it. But this is important because it can interact with methadone by prolonging its half-life. Somebody who has sleep apnea and somebody who has liver dysfunction is also at risk of toxicity. Somebody who doesn't have any concurrent health conditions, perhaps they're younger, they're healthy, they're not using other substances or medications that put them at risk, is somebody we would say does not have major risk factors for toxicity. So this is just a recommendation and a guideline. Obviously, you would make your own assessment around, is this somebody who's got low tolerance, high tolerance? Is this person high risk of toxicity, low tolerance? Are they, so a lot of this is going to be clinical judgment, but we just put some factors to consider on the left-hand side and some recommendations, the recommendations for initial dose and titration. So for somebody, for example, who had low tolerance, but was really high risk of toxicity, you might want to start really low, something like 5 to 10 milligrams of methadone. Again, using your individual judgment for that person, and then titrate 5 to 10 milligrams every 3 to 5 days. And then one of the comments we put in is for somebody like that, you may want to strongly consider using buprenorphine over methadone just because of its much greater safety profile and lower risk of overdose. Somebody with moderate tolerance, but who's at risk of toxicity, you might want to start at 10 to 20 milligrams of methadone and then go up by 10 milligrams every 3 to 5 days. And an example of that might be somebody who's using OxyContin, 80 milligrams 3 times a day, or they're on hydromorphone, 8 milligrams 8 times a day. Moderate tolerance, no major risk factors, 20 to 30 milligrams. High tolerance and risk of toxicity, 20 to 30 milligrams. And what we also put here is that below 80 milligrams, you can go up by 10 to 15 milligrams every 3 to 5 days. But once you get above 80 milligrams, because usually the dose that you're aiming for is usually around 80 to 120 milligrams. Those are the doses that have been shown to be associated with better treatment retention and better outcomes. So once you reach 80 milligrams, going up to 10 milligrams every 5 to 7 days would be reasonable. Somebody who has high tolerance and no major risk factors for toxicity, we're recommending an initial dose of 30 to 40 milligrams, being able to increase by 15 milligrams every 3 to 5 days, and then by 10 milligrams every 5 to 7 days after 80. And somebody who has got very high tolerance and no major risk factors, we recommended 40 to 50 milligrams of starting dose of methadone. And again, the same guidelines around below or above 80 milligrams. And an example for somebody like that might be a young person who's not taking anything sedating, who's otherwise healthy and who's using a daily fentanyl doses that are higher than a gram a day. And especially if they've had evidence, like if you know that they've recently been on methadone, they may still be protected somewhat by that. One thing that we just kind of wanted to point out is that these are slides from the Toronto Drug Checking Program. There have been a lot of changes in the drug supply. And I mean, I don't know, next month, this could completely change again. It will change regularly. So we just kind of wanted to point out that we made these recommendations and guidelines in the current landscape, but this is an evolving one. So if you look at this slide, it's a little bit busy, but you can see that the purple line, that kind of like the pale purple, is going up towards the end, and that is veterinary tranquilizers. And you can see benzos, which we've always been so concerned about, the blue line is going down. So as the purple line goes up, the blue one is going down. So increasingly, the drug supply is being contaminated, and fillers that are being used are veterinary tranquilizers as opposed to benzodiazepines. And anecdotally, I've been noticing that too with a lot of my patients. Their urine drug screens are not positive for benzos routinely the way they used to be. So that's been a bit of a shift, and it could affect presentations. It could also affect, I mean, I'm not really sure how that's going to affect risk of sedation, and veterinary tranquilizers are still concerning. I think it may change how people are presenting with their withdrawal. You can also see that there other fillers are changing as well, but those are the two big ones I really wanted to point out. So this is also, I thought, was really interesting. This is the number of high potency opioids in expected fentanyl samples. Now, I realize this is Toronto data, and many of you are from different places across the country, and so sorry to be so Toronto specific, but this is kind of what data I had access to. And you can see here that the number of drug samples that they checked that had 3 or more high potency opioids, peaked a little bit from the spring to fall of 2024, and then has fallen a little. But the number of samples with just one high potency opioid that was found has decreased. And you can also see recently the number with 2 high potency opioids has increased. So it's constantly changing. But the other thing is, overall, you can see that the total percentage of samples with high potency opioids has gone down. So at its peak, you can see in like 2020, it was close to 100%. And then now we're looking at 60% is what it's at its peak for 2 high potency opioids. So the number of samples with higher potency opioids has also shifted. What's in it has shifted, but also how much. And then in terms of the amount of drugs found, this is also something that has really changed. If you look at the bottom of this table in January of 2024, the average amount of fentanyl found in the samples was 6%. And in October of this year, so just the 50 samples that they've checked so far this year, it's just over 1%. And so it's a lot less fentanyl. So it's changing, and that may affect your assessment of toxicity and what you're seeing in your community. And I mean, I'm not sure how much that would play into your decision around how high risk somebody is for toxicity or what their tolerance is. So I guess more around what their tolerance is. Next slide. So just for my section in closing, I mean, I think the 3 independent main risk factors for when you look at the literature for iatrogenic overdose is somebody who's got low opioid tolerance, somebody who uses a higher starting dose. The vast majority of iatrogenic methadone toxicity cases happen in the first 2 weeks of treatment. So that's when it's really important to do your careful assessment of risk for toxicity and tolerance, making sure that, you know, that balance between wanting to make sure somebody's retained in treatment feels comfortable, feels like their withdrawal is being addressed, and at the same time, keeping them safe. And then the other main risk factor for iatrogenic overdose is the presence of sedating drugs or other substances. So I think if you can pay attention to those 3 things, it will really help you come up with a tailored program for each individual patient around something that would work best for them, that best balances their safety along with the need to get them into treatment quickly and get them to a comfortable dose as quickly as possible.
So we're hoping, as Anita said, that holding those pieces in mind, you may or may not have the guidelines open on another screen, that we would use some of these cases to discuss the various factors and how we think about them. So this will be a bit of a conversation between the 3 of us, and I'll try to keep an eye on the chat as well. And just overall, you know, these are sort of composites of patients designed to highlight different issues. They're certainly not specific individuals and not intended to you know, represent any one person. But let's imagine we're starting talking about Mickey, who's a 40-year-old male who was on methadone up to about a month ago. He was up to 130 milligrams at the time. He comes back, reports that he's been using a gram plus of fentanyl a day, both smoking and injecting. He also uses some crack and crystal, though not every day. He says he doesn't use benzos or alcohol. At the time that he comes in, he has some cellulitis of his left hand. He has a long-standing diagnosis of bipolar affective disorder. And on his urine sample, he's positive for EDDP, which is the methadone metabolite, positive for fentanyl, cocaine, methamphetamines, benzodiazepines, and hydromorphone, and negative for oxycodone and buprenorphine. I don't know about all of you. Those are all the things that I can typically test for in my clinic. There may be others who have slightly different point of care tests. Oh, I don't think I put on there morphine. Let's say that he is, we'll call it negative for morphine, but positive for hydromorphone. So, Anita, how do you think about this person in terms of the tolerance and toxicity?
Yeah, I mean, I think this person is, you know, seems like he's young and otherwise fairly healthy with no other risks, and he's using a lot, and he's clearly positive. It's interesting to me that he's positive for EDDP, but it's been a month since he's been off of treatment. So it suggests that he may be getting methadone from someplace else. So I would feel comfortable with somebody like this, who I know had been on methadone in the past, who had a QTC of 437 with being, and he's been off of his Riprazole and lorazepam. I feel comfortable starting this person at a higher dose. One thing we didn't talk about with our starting doses was, you know, would you add morphine on top of it or not? I think with somebody like this, I would want him to feel comfortable as soon as possible. He's clearly suffering and has got cellulitis and has very high tolerance. So I would feel comfortable, and actually the presence of EDDP might even actually make me feel a little bit more comfortable. I don't know. I mean, it probably is supposed to make me feel less, but it might make me feel more depending on what he said. If he said he'd been using his friend's methadone for a few weeks, I would feel even a little bit more confident.
Yeah, I would agree. I think especially if he acknowledged using someone's methadone and had some idea of what he was using, It's always a little bit more, I guess, reassuring when it feels like there's alignment between what's in the urine sample and what someone tells you that they're using. Before we sort of hit that next slide in the plan, Andrew, do you have any thoughts and comments about this person in this scenario?
And we can't properly capture what happens when we sit down and we talk with somebody. Um, you know, a lot of times somebody would see that somebody just, you're not regularly showing up for appointments. You're not here. We spent a lot of time. We got you to this therapeutic dose. What's going on? Where are you living? That may affect how we're going to proceed in certain things like caries. How are things going? You've got this long-standing diagnosis of bipolar. Are you medicated? What's your housing situation look like? When was the last time you ate? Sitting down and having conversations with somebody in regards to stuff like that. Putting somebody's mind at ease. We said that if somebody's using somebody else's methadone, that might put as a prescriber your mind at ease to understand why this person has methadone in their system when they in fact don't have an active prescription. As somebody who routinely bought methadone off of the street when I was sick, I as a person walking into a clinic had a feeling that I would have gotten in trouble for telling the truth, that my prescriber would have been upset with me. When in reality, that's not a reflection of the truth. So being able to sit down and have that conversation and let the person know, listen, you're not in trouble. I'm just wanting to get an understanding of what's in your system so that we can better get you back to a dose that would help you. That's what stands out for me.
Thanks. Yeah, I see a question in the chat. In previous recommendations, the presence of EDDP at first presentation was considered a higher risk for toxicity. And in fact, I remember that we couldn't start someone on methadone if they had methadone in their urine or were not supposed to, because we had, at that time, patients had to be registered with the college and we needed to know that they weren't already associated with another prescriber. And I can still remember seeing someone who came in really so anxious to start, and I had to say, no, I can't. I have to get this approval from the college before I can start treating you. And so I think this idea around toxicity is really interesting. At that time, we really worried that it meant that people were already self-medicating with methadone, which we thought was the most toxic of the opioids. And I think our perspective has really shifted in the days of fentanyl, right, which is more toxic. And that's not to minimize the risks of methadone toxicity, which is why we're not starting everyone at 60 and 80 milligrams. And in that sort of, green, yellow, red stoplight paradigm, it's not to say that there is, no risk. We're truly trying to sort of gauge that question around the risk of someone who is using whatever it is that they're using and the risks that they will experience if they don't get onto treatment. So if we went back to those previous days and put someone at 20 milligrams, that's really not going to approach their tolerance at all, then I think we risk the likelihood that they say, why bother, right? And
I
I
think
think you had something you wanted to add to that.
I think for me, the biggest issue would really be how long had they been using that methadone for? If somebody came in, had never been on methadone and tested positive for EDDP, and so they had tried it for the first time the day before or in the last couple of days, I would be much more cautious with my starting dose because I wouldn't want to, add to the cumulative risk. But if they came in and said, yeah, I don't know, I live with my partner and they've been sharing their methadone with me for the last couple of weeks, so I haven't been able to get into clinic, and I felt that it was, I felt that there was, it made sense, and I had no reason to believe otherwise. I would then feel a little bit more confident that that person, had some tolerance to methadone, had some enzyme induction going, and was a little bit more actually a bit safer. So I think the timeline for me would really be the key factor here, and that's where the history would really come in.
Yeah. There's another question here. Some point of care tests show both methadone and EDDP. I have to say I've never worked in a setting where we had a test that showed methadone. I've only ever seen EDDP in my clinical settings. But the question is, for legal and documentation purposes, what is the requirement to be able to confirm whether or not there is presence of methadone versus EDDP, which doesn't usually show up for weeks, having seen this many times in practice. So, Anita, I'm going to put that to you if you're okay, and then I have maybe some additional thoughts depending on your answer.
I haven't had that experience, so I'm actually trying to remember in my clinic if we even check for methadone. I don't think we do. I think we just have EDDP. I'm trying to visualize it. So I mean, I guess the advantage if you did both is if somebody just put some methadone in their sample and they weren't actually taking it. I've never ever actually seen anybody do that. So I mean, I think if you could only have one, you would want EDP, but how long it takes to show up, I haven't had it take weeks to show up. I've had it showing up pretty quickly, so I don't know. That's not been my experience, but obviously it has been Helen's. So
Yeah, I think the key thing is that if someone is ingesting methadone, you should see the methadone metabolite, as opposed to methadone being added to a urine sample if someone were tampering, which is not the focus of this talk, but that's when you would see methadone in the urine typically. EDDP will show up the next day in my experience. And also, there is no legal requirement to document either methadone or EDDP, right? So, in fact, there's no legal requirement to document a urine drug test, like to obtain a test or before starting someone on methadone. We certainly recommend that before starting someone at higher doses, that there be some kind of confirmation around fentanyl use, and that could include collateral information from Connecting Ontario, hospital visits, previous samples, someone that you've worked with previously. Obviously, if you do a test, then you should be documenting the results of that test. And again, I would recommend a urine sample whenever possible before starting someone at high dose methadone, but it's not an absolute requirement as long as you can obtain some kind of information that makes you feel really comfortable that the person, in fact, is using fentanyl and has that high or very high opioid tolerance. Does that make sense?
Yeah, I am curious to know about Helen's experience a little bit more, though. So my understanding is that you're seeing samples that have methadone present for weeks, but not EDDP. Is that correct? For people who you're prescribing it to. Okay, we can move on.
Feel free to add into the chat.
Yeah, add it to the chat.
And perhaps we can come back to it later if we haven't answered the question. Some have shown methadone and not EDDP. Yeah, that would make me wonder about whether methadone was being ingested or not.
Yeah, that would be concerning to me.
Yeah. Okay, so drawing from our sort of previous chart, this person would meet criteria for very high tolerance. There is some evidence of methadone use, let's say by sample and by self-report. They're using fentanyl plus hydromorphone plus methadone, so they clearly have high tolerance. So you could choose to start them at 50 milligrams. And then what else do you think, Anita and Andrew, thinking about some of these other kind of points?
I guess in terms of the restarting of the other medications, I think I'd probably want to know a little bit more around the therapeutic indications for them and how the patient was feeling without them. Maybe also could be a staggered restart, or it could be something that they're not really missing. You could hold off in the interest of trying to kind of balance that off, but being able to be a little bit more aggressive with the opiate agonist treatment. So I might hold off on that depending. And in terms of the antibiotic daily dispensed, I do often do that, or at least the first dose, like if it's kept like BID or something, to have them do the first dose to observe and then take the second one home. And part of that's just around the structure, so that there's that reminder that you should take this every single day. It's often really helpful. Just a lot of my patients have said to me, yeah, I would forget to take my antibiotic otherwise. And since I'm going in for my methadone anyway, it does make it a little bit easier.
Yeah, I find that a challenge because if you dispense the antibiotic every day, but the person doesn't come to the pharmacy, then they miss their antibiotic. So sometimes I'll ask someone what they think will be better for them to really be able to take it and remember. I think that I would start prescribing at the same time as starting methadone. I know I'm always tempted to try to get someone back on previous therapy, but I think in the interests of being able to observe and our cautions around sedation, I probably wouldn't restart aripiprazole right at the same time as restarting methadone, especially at a higher dose. And I'm always looking for an opportunity to not restart lorazepam anyway. So I would certainly kind of hold off, although, there are lots and lots of requests for that, especially from people who've been on it before, around anxiety and agitation. But I think to the charts that you shared earlier, Anita, do you want to say anything about benzodiazepine withdrawal and some of what we've sort of heard or discussed around prescribing benzodiazepines to treat that withdrawal and people restarting methadone?
Yeah, I do give benzodiazepines a lot at the beginning, or I used to. So if in this case says to you that he hasn't had prescribed lorazepam for a month, so and if he tells you that he hasn't been using any benzodiazepines from another source, and he had tested, I forget, his urine dopamine was positive for benzos, right?
Yeah.
So in that case, I probably would give a few tablets, just because he's going to feel unwell from the benzodiazepine withdrawal, and maybe not right at the get-go, because if he's still using fentanyl alongside his like if he's still using fentanyl alongside the methadone induction for the first week or so, then he's going to be getting some of that benzo. But as his fentanyl use tapers off, I would be probably, I've found it doesn't take very much, like 0.5 milligram of lorazepam for 3 days is usually super helpful for a lot of my patients with the benzo withdrawal that they experience. But anecdotally, I have noticed that a lot of the newer starts that I've been doing have been testing negative for benzos. And so in that case, I haven't been.
Yeah, and I think we had a lot of discussion about the fact that people are very often still using when we start them on methadone. And so if they're sort of, self-titrating down, they're not going to full-blown benzodiazepine withdrawal as they would if they were being potentially admitted to a setting where they don't have access to opioids. So in an observed, hospital setting, for example, there could be more of a rationale for offering some benzodiazepines briefly. And we do talk about that in the full guidance document, and I think there's reference to a protocol that came out of Alberta. It's short, it's 3 days, and the idea is not to begin a very long, drawn out benzodiazepine prescription and taper. It's really intended to be very short term. There's a couple of questions about benzodiazepines in the urine sample. And so, Anita, the question is, how do you factor that in terms of your assessment around risk of toxicity? Because again, going back to our old days, if someone had benzodiazepines on a first presentation, we'd be thinking about starting them at 10 or 15 milligrams, sort of going extra low because of concerns about the risks of sedation.
Yeah, I think that I'm remembering my first assessment from the college where I got in trouble because I was prescribing methadone to somebody who was also using some street Valium, although he'd been on methadone for years, and I was, absolutely can't do that. He was on 5 milligrams of Valium, but it was, I think it really depends on, is this a chronic prescription or something that they're regularly using? If it's something new that you're introducing at the same time, or it's intermittent use, but if they have really high tolerance, I think you're always just kind of trying to weigh that against the risk of, the risk that they don't stay in treatment, or that they're using fentanyl, which is going to be much riskier for them. So I think in this case, his benzo screen is positive. And I think, again, this is where the history really comes in. He says he's not taking lorazepam. He hasn't taken it for a month. He's not using it elsewhere. So it's most likely the source is his fentanyl from, like, his street fentanyl use has got those benzos in it. And so, I mean, I think I probably would still just treat him the same way in terms of the methadone dosing. I would really be focusing on his high fentanyl use. Um, that's how I would see it. But if there was any history of other benzodiazepine use, then I would be more careful. If he was
Yeah.
prescribed it, if he was using it on top of fentanyl, then I would factor that in.
Yeah, and we're making all of these decisions based on a point of care test, what we think we know about this person and what we're getting in this visit. You could also send urine samples out and see what else is coming up and do that over time to see whether, what benzodiazepines are showing up there and gather some more information. And of course, sometimes things come to light over time as people share more information about what else they're taking, whether they're getting some, quote unquote Xanax bars or not. Um, Again, to this question of, how long do you extend a benzodiazepine taper? My concern is that the longer you stretch it out, the harder it is to ever stop the benzodiazepine. So I find myself very unsuccessful in discontinuing benzodiazepines. And so again, I think there are some people where it seems as though the methadone, the opioid withdrawal symptoms seem to be reasonably well managed. And they're still struggling with other symptoms, especially if they were actually using benzodiazepines, not what was in the opioid supply. And I don't know what you think, Andrew, Anita. Sometimes people present with different symptoms, feeling very hot, flushed faces, feverish, not sort of the runny nose and upset stomach and that kind of thing. Um, that would be my primary reason for prescribing benzodiazepines when people are trying to stop using street benzos as opposed to trying to stop fentanyl.
So we a couple of things came up that I was thinking about, and I was flashing back to a period of time. Your first question here, and in regards to the benzos, if somebody is utilizing street fentanyl that contains benzos and they are looking to reduce their use, they're likely not going to experience the same kind of withdrawal that they would, like you said, if they're walking into a treatment center, a custodial facility. So, depending on what environment they're in, for me, would determine whether we're going to initiate some kind of a very brief taper off of benzos. The one thing that stood out was the pharmacy that's accessible to him. We saw that he was on a high dose of methadone for a period of time. And I say a high dose because to me, 130 milligrams for back when I was on methadone would have been considered a high dose. I know it's not necessarily by today's standards, but why did he fall off? What happened? Did the pharmacy that he was accessing play a part in that? Was he out of town for work? Was it as a result of getting picked up by the police or other things that I know have all those situations happen to me? What came to mind was the fact that every Sunday I used to access a pharmacy that was open from I think it was from 12 p.m. till 2 p.m. or 12 till 1. It was like a 1 hour block. And I never was successful in ever getting to that pharmacy. And the odd time I would also miss the day before. And then it was really easy to fall off. So working with somebody to find out what's the best situation for you in order to be able to make sure you don't miss that and even considering when we restart somebody, I know that there's guidelines surrounding carries, but what's going to have the best result of getting you back re-engaged on this life-saving medication? That's it.
That's great. Okay, so fortunately, we already dealt with the first question. The second question, third question, Anita, any concerns in terms of starting doses around the stimulant use?
No, no, before we go into that though, I love Johnny's question around if benzos are cut in and someone continues, aren't you always trying to chase it? And I know we sort of touched on it a little bit, but I just want to say what I often do is if someone says to me that they're having difficulty with withdrawal and they're really trying to cut down their fentanyl use, is I will frame it as a trial. And I'll say, let's just try this a couple of times. And it's a 3-day prescription and it's short.
Mhm.
And after we've done it a couple of times, like on sort of non-consecutively, if they don't really feel like it was helping them cut back, then I'll just say no. And at some point, I will say, well, what's the end game here? Like we've tried this a few times. It doesn't seem to really be helping. If you continue to use fentanyl at this point, I don't think it's the benzo withdrawal. And then I don't do it anymore. But usually it has helped a couple of my patients just the first few times. And they say, I'm really trying to get back, but I'm experiencing withdrawal. And it's not classic opiate withdrawal. And they're really having difficulty cutting down their fentanyl use, and their urine drug screen is positive with benzos from what's likely the the contamination of the fentanyl. I have actually found it helpful, and I will try it once or twice just for a short 3-day prescription.
Yeah.
Regarding the stimulant use, I mean, obviously it is concerning. I think at this point, the greatest risk to him, though, is the fentanyl use and his high risk of overdose and getting him in treatment. So I think I might address it, but at this point, I would maybe put it down for the next visit or the third or fourth visit and really focus on his opiate use right now. Regarding the QT prolongation, I mean, getting to what Andrew said about, what was going on with the pharmacy, is Suboxone going to be, or buprenorphine going to be easier for him if he's got QT prolongation? It's easier to give take homes right away. Would he be a good candidate for buprenorphine extended release subcutaneously? So there might be some other options to consider there. If there was QT prolongation, and especially if the context of, he was off methadone for a month, were there issues around getting to the pharmacy, or just around it just being too complicated, or like being a full-time job?
Yeah. Great. Okay. In the interest of moving to our next cases, those are all great questions, and we could obviously spend time really kind of delving in. Okay, let's talk about Penny, who is a 63-year-old female using fentanyl between a half and a gram, so sort of 5 points or so, and up to a gram a day. And she's not injecting. She says that she snorts it. She's not using other substances except tobacco. She is scared. She's had too many recent sort of, little overdoses, and she wants to take steps. She was on methadone over a number of years in the past, but she hasn't been on anything. She comes in, she decided, it made sense to try injectable buprenorphine, the long acting, to try to get to that dose quickly, block fentanyl, block the desire to use, but it just wasn't working for her, despite having done a couple of closer injections, really trying to sort of get to that threshold. Obviously, this is a talk about methadone. So she tried it, didn't work. In terms of her medical issues, she's HIV positive. She had remote endocarditis and hepatitis C. Her urine is positive for buprenorphine, fentanyl, morphine, hydromorphone, and benzodiazepines. Before we go to sort of what is our next, any questions or thoughts, Andrew or Anita, in terms of what's going through your mind? It's okay. We can move forward.
Good.
The only thing that I think is often missed or skipped is, and it takes us back to that slide that said it's more than a dose. And a lot of times you can learn a lot about somebody and what's going on with them in a very brief 5-minute conversation about what are your goals, what is it that you're resistant to this, why is it that you're resistant to buprenorphine, what's happening with you in regards to this, what are your goals? And I think that that's something that's really important. I mean, she was on methadone, but she's not anymore. What happened?
Yeah.
Because it's possible that there's more going on than what you're seeing when you look at the results. That's all.
Almost for sure, there's a lot more going on, right? And so I think, acknowledging that, and what are you going to deal with in the moment, right? What's she prepared to share if she's new to you versus if you've known her in the past, and acknowledging that there's probably been a lot, and you can get to that if she wants to discuss it or not. What's the focus for right now, for sure. Yeah. So I think one of the main reasons that I wanted to highlight this and was thinking about medications and medication interactions and some of the resources. Again, these are all listed in the guidance. They're on a note on page 14, and I've stuck them as a sticky on my computer so I don't have to go looking for them. To think about all of the cytochrome inducers and inhibitors and QT prolonging medications. So when I looked at her Biktarvy, I'm like, oh, I know this is an antiretroviral and what it does something. But it has a green in terms of drug interactions. I don't think we talked before about aripiprazole and the antipsychotics, which can also be QT prolonging. So the more medications people are on, the more opportunities for interactions there are. And I would say that doesn't affect their initial dosing as much as it affects their titration and sort of high doses, unless there are big medication changes, right, which can affect the metabolism of a medication. Anita, do you want to add to that?
No, I agree. I was actually just trying to sort of think creatively for her, like if she, if this is going to be an issue for her, she was on methadone. There's obviously a reason she stopped. She went on subcutaneous extended release buprenorphine. It's not working so well for her, but yet she's got some risks with her age and her other medications. So, is there another way? And I'm thinking, like, would it make sense to maybe offer a trial first of adding some buprenorphine sublingually on top of her subcutaneous medication as well. I think or even just another opiate agonist that's not methadone. I'm not sure how much blockade, if she's not getting a full blockade. So I'm just trying to think of, like, before going to methadone, just given her other risk factors. But I agree that if you were going to go that route, to kind of proceed carefully, because she does have some concerning, like, some risk factors there.
Yeah. And I think those are all great points, right? To think about the risks and shared decision making. And again, we're running a little webinar on methadone. So here we go. So in this case, thinking about the level of tolerance and the risks for toxicity, would you start her at up to 40 milligrams based on what she's reported around her use and her meds?
I wouldn't. I might start her a little lower, only because she does have buprenorphine on board already. So she's got a pretty strong base there. And I would be worried a little bit. I might start her at 30, but that's just me. I don't think there'd anything wrong with starting her at 40. I might just think, well, she's got some buprenorphine on board, and she does have other medications. I forget what her I might want to know what her QTC is.
Mm-hmm. But you wouldn't require an ECG before starting her?
No, not at all. But I mean, if I had that, like, readily accessible or real, I have like a cardia in my office. I'll just really quickly do it sometimes on somebody, just to quickly see. But if I didn't have that information, no, I absolutely would not wait. I would just go ahead and start. And I think 40 would be reasonable. I might just be cautious, but that just might be 30.
Yeah. When we were discussing this case, we were discussing the sort of almost like a bit of a contradiction or a conundrum around the fact that you might think that buprenorphine is blocking those opioid receptors, right? At least partially. So how much methadone effect is she getting? Is she actually getting relatively less than someone who was not on that? At the same time, she also has some of that buprenorphine effect. And so I think it would be totally reasonable to start her at a lower dose and observe how she did. You certainly wouldn't start her at 50 based on everything that we're saying. I think that's an important takeaway from this. Yeah.
I mean, just play devil's advocate. Conversely, the buprenorphine would also be very protective against overdose as well. So I mean, probably could start her at 40 much more safely than as if she didn't have that on board.
Yeah.
I mean, I need to, because she's got it on board, but it is protecting her somewhat as well.
Yeah. So is there any guidance on starting MMT with recent Sublocade dosing? I don't think, with respect to the question of what is the guidance, I don't think there's like something from the company around what to do. But if someone is not doing well on their buprenorphine, whether it's sublingual or it's injectable, and you need to move to a full agonist, then you need to do that. And I think, as we've said, they have the protective benefit but also some opioid on board. And so it's a little bit of trial and error. Certainly with sublingual buprenorphine, you know that it's going to wear off and be out of their system really quickly. With the injectable, it's lasting for much longer. And so I think if you get to, 4, 6, 8, 12 weeks and they seem to start experiencing some withdrawal symptoms, that may be the drop in buprenorphine. And people might need an increase in their methadone or their Cadian when you wouldn't necessarily think otherwise if they were stable that they should need a dose adjustment at that point. Yeah. Anita, do you want to answer the question? Would you add Cadian in the mix if concerned about QTC? I'm assuming that's a question where we've already added methadone and you're thinking about how high to go on methadone versus adding SROM to methadone. Yeah.
So would I add Cadian on top of the methadone? I think if she was really uncomfortable, I would feel comfortable doing that. It would, I think, make sense. It would allow you to get her to be comfortable more quickly. And I agree with you. You actually may find that you need doses lower than you might for somebody who didn't have that buprenorphine on board, and it is protective. So I think just sort of discussing it with her, if she said that she was really uncomfortable, I think it would be reasonable to add in some morphine on top of methadone, especially because she has that protection.
I mean, I think what's interesting is we're assuming that we have an ECG, and so often I don't have an ECG to look at. And so, we're often looking to see if we can find one from a hospital admission or in Connecting Ontario, really trying to get one. Certainly if someone is really using fentanyl actively, the risks from fentanyl are higher than the risks from methadone or methadone plus stimulants. So that's not a reason to not be increasing the methadone unless they have a QTC that's substantially elevated. And then yes, in that case, you might be wanting to reduce methadone and replace that a little bit with Cadian. And we could have another webinar talking about that maybe. So great questions. But yeah, if you're really worried, and obviously if someone has risk factors for torsade ventricular arrhythmias, then you might not want to be starting methadone at all, right? Or keeping it really low overall. Before the third question, okay, the question is, first follow-up is 4 days. I'm curious if that's what your goal is for more frequent assessments initially. I've been assessing after 1 week with 1 to 2 up titrations. I'm assuming that means a planned dose increase in the interim, or maybe by phone assessment after 3 to 4 days if possible. So yeah, totally agree. There are lots of barriers in terms of getting to clinic. So great opportunity. I think this will actually take us into the next case as well. But Anita, do you want to speak to that? And then maybe Andrew also.
Yeah, I think there's just so many variabilities. I think every practice situation is so different and every patient situation is so different. Maybe they can't get the time to come in, or maybe maybe it's a stat holiday or for whatever reason. So I think just sort of being flexible and trying to kind of craft something that works for the way your practice works as well as what worked for the patient. And it can be really hard sometimes to have it exactly timed right.
How do you feel about pre-planning a first dose increase in someone without some kind of contact with them? If you don't already know them, it's not a restart, let's say.
So it's the very first time that I'm starting them.
That you're starting them. Mm-hmm.
For me, I feel more comfortable if it's the very first time and I don't know the person, and especially if maybe they live alone or I'm not sure what the situation is. I prefer speaking with somebody, or at the very least, making sure that they're going to a pharmacy where I feel comfortable that the pharmacist is pretty good at laying eyes on them. Or sometimes like if they don't have a phone, sometimes I'll ask the pharmacist to call me. I'll give the pharmacist my cell phone. Like I prefer to speak with somebody if I don't know them. If it's somebody who I'm restarting, I feel much more comfortable, and if I know them. But if it's the very first time and I'm not sure of tolerance, I will try and do either an in-person assessment or at the very least a virtual one.
Yeah, I think I would agree. Restarting or someone that you've known feels different than if it's the first time you're starting. And if you can be flexible and do a video or phone or some kind of check-in with staff, at least at the first dose increase. Subsequent to that, if there are challenges, weekends they've missed, I think that's where I would feel more comfortable with doing that. Yes, there was a really interesting. Oh, okay. Lori's sharing. I guess there's a Q&A that we can't, I'm not seeing. I think I actually might have posted this study on the listserv. It was an article about restarts. It wasn't new starts, and it was people who had been on methadone. I don't remember the doses overall, and off methadone for actually up to 30 days. And they were all essentially restarted at very close to their previous dose with no adverse events. I think thanks, Sarah, for posting the article. I think it's really interesting. Again, I think it is a little bit different in the context of it being a restart. I'm still not 100% sure that I would feel comfortable restarting someone at, 100 milligrams after a month of being off. But I think it's an example of emerging evidence that we all need to stay attuned to. I remember that one of the things I found really interesting in that article was that although there were no adverse events and it seemed like a great idea to get people back to the dose they had been at prior to missed doses, there was actually no change in long-term treatment retention. And to me, that's a message again about the fact that the dose is really important, but the dose is not everything. And we need to keep learning from these articles and keep learning from our experience, our colleagues and our patients. Let's try to move to case number 3 because time is flying. So this is Nikki. She's a 35-year-old woman. She's been on methadone, 60 milligrams for almost 3 months, having a really hard time getting to the pharmacy. And so she's sort of gotten stuck at 60 milligrams. She just found out that she was pregnant. So by ultrasound, about 15 weeks, she wants to continue the pregnancy, but has a lot of misgivings and anxiety because of experiences during her previous pregnancies. Since finding out that she's pregnant, she's really trying hard to cut down, but she's having a lot of withdrawal. And her urine screen is positive for EDDP, so methadone metabolite, fentanyl, some benzodiazepines, and hydromorphone. So we're going to try to move through this. It looks like, Andrew, do you want to start with some of your thoughts and considerations?
So I thought the same thing with the last person you were asking in regards to changing their dose and what did that look like. I'm always somebody who's been a proponent of providing a carry to somebody, whether it be on off days, increasing a dose whenever possible, if that's going to get them to a therapeutic dose, understanding that there is risk involved in methadone overdose. The likelihood of somebody utilizing street fentanyl is much more dangerous, and that's what comes to mind. If somebody's having a hard time getting to the pharmacy, and they are, and I'll speak for myself. If I was not able to get to the pharmacy, I have somebody in a way that I will absolutely treat my withdrawal. And the problem is that my treatment for withdrawal often kills me. So what can we do to better help somebody who's in this situation? The first thing comes to mind is consider carries for this person. And I mean, this person hasn't been on methadone for a long time, but now, withdrawal is incredibly dangerous. And what can you do to help reduce their use, especially considering that they're pregnant?
Yeah, thank you. Anita, do you want to speak to sort of dose increases in someone who's having trouble getting 3 consecutive doses?
Yeah, I agree with everything that Andrew said, and I think that hopefully the missed doses would go down with the increased flexibility with the take homes. It looks like her young children are not even in the home, so in terms of risks and making sure that it was appropriately locked up and all that kind of thing. So in terms of missed doses, maybe this is not what the JAMA article would say to do, but in our recommendations or guidelines, we said that if they have had 4 out of the 5 last days, am I getting this right, that you could continue the dose, you would have to have had, let's get this, I'm always having to look this up myself. If they missed no, I have the chart on my thing here because I'm always like, what's it again? So if they have missed a dose, but they've had at least 2 in the last 5 days, and you can increase it.
Yeah, the main thing being that they didn't just miss the
They
day
didn't
before
just
they were
miss.
seeing you. So you could see them continue the dose and then plan a dose increase for the next day. So you don't have to wait to see them back. Take the chance that they're going to not get 3 doses again. You dose them on the day that you're seeing and then plan the increase for the next day. Would you think about putting someone like this up from 60 to 80 instead of 60 to 75?
I would, because she's been on it for 3 months, so
Yeah,
she is very tolerant, and she's pregnant. I forget, she's how many weeks?
15.
15. So her needs are increasing rapidly at this point, and
Yeah.
she for 3 months. So I would feel comfortable doing that, and I might offer some supplementation as well with some morphine. So,
What might you supplement her with?
um, I mean, I would talk to her to see if she would want it or not,
Mhm.
but I might
Mhm.
supplement with some morphine.
Yep. Yep. I think that would be fair.
The other
And
thing,
then,
sorry, the other thing I consider is split dosing for the methadone, especially since she's 15 weeks. And so often I find in pregnancy that the dose needs to be split as it
yeah,
progresses.
so often. So I don't know. Well, we'll try to move through quickly. But to Andrew, and your point about carries, I think we want to think about can the carries be kept safe? So she has already been on methadone for more than 8 weeks. She is missing some doses, but getting more than not. She's really trying to reduce. And the faster that we can reduce the number of missed doses, the better she's going to do in terms of stabilizing. So with a review of all of those things and the issues around carry safety, I think it would be totally reasonable to start her in that category of not full carries, but up to 3. And to be honest, I don't always stick to the non-consecutive carries. I often will have a discussion for people about which 3 days are going to make the most sense for them. And then what it's going to take to move from, up to 3 to more carries in terms of seeing increasing stability, seeing that they're getting their doses, they're not having challenges with them, and seeing things stabilize over time. Um, so yeah, just briefly, Anita, when would you think about split doses and what do you do about carries? If you have someone who really had to kind of 0 carries, and then if you're thinking about split doses, you're effectively going to 7, right? Would that concern you?
Like extra carries. It's interesting because we often talk about carries and how many days. I sometimes just think of the total dose. Like it almost sort of strikes me as like I might give somebody 1 carry, but they're on 120 milligrams, and somebody else who's on 30 milligrams, is
Mhm.
like it's like what the total dose is and what's their safety profile. I guess if she is living alone and I'm not worried about depression or that she may be taking more than she's supposed to be taking it, if I feel confident or comfortable that she's taking it appropriately, I would be okay with the extra carries and the split dosing and just
Mhm.
having her take it home. I usually don't ask people to go to the pharmacy twice in one day. I feel like that's a lot, especially if you're just like if her total daily dose is 60 and you've now made it 40 BID, you've only gone up by 20. So to make her go in to do the 40 observed and then or take the 40 home and go in for one observed dose, I just
Yeah, and if you make someone go twice, odds are they only get one of their doses, so you're actually getting a net dose decrease rather than an increase. Okay, some rapid fire, 4 minutes. What if someone doesn't want all of the sugar that's in Tang? Do you have any recommendations or adjustments around that?
I just asked the pharmacist to use something sugarless or to reduce the volume to half.
Yeah. So speak to the pharmacy. You can write on the prescription, please dispense in lower volume, or have the patient talk to the pharmacist about bringing in a sugar-free beverage like a Crystal Light or something like that. Um, we decided what we would try to focus on. What if someone misses appointments? How long will you extend prescriptions? And at what point, like, what's your next move if someone has missed 1, 2, or 3 visits?
For me, that's challenging, but also a very common scenario.
Mhm.
I will usually try and get in touch with somebody, see if I can even speak to them virtually, figure out what's going on. Um, I will usually extend it and do that for a while. But after a while, if I feel like I haven't seen the person for a while, or I'm starting to worry about their safety, and I really want to check in, I will sometimes leave a message with the pharmacist saying, please have them come in or call me while they're at the pharmacy. It doesn't always line up though, right? Like the pharmacist might call and I might not be in the office. So I will do it for a while. And then at some point, I mean, I don't know, so individual, case by case. At some point, if I can just even get them on the phone to have a conversation, like, is this the right place for you to be coming? I might not be the right person. I'm not here enough, or my hours aren't great for you. Maybe you need something closer to home, and I will try and help them problem solve to find a clinic that might be closer or better for them, or that works better for them. Maybe appointments aren't good for them. They need a place that they can go in that has like longer hours, drop in. So I'll try and work with them, but I don't know if I have a ready answer for that. It is it's frustrating, and I try really hard to be flexible and keep people in treatment. But at some point, I have sometimes just said, you know what, I've written on the prescription saying, please tell them to come in. I won't be able to issue a prescription after this, and it usually works. People usually come in at that point, but that's usually after I have extended it a few times.
Several times, I'm sure. Yeah. Yeah. Andrew, what are your thoughts on that?
So I would have pushed it as far as it would go. My thought is if somebody's not missing doses, that extending them 2 times, even a third time, is there's nothing wrong with that. However, the relationship matters, and having some history with the person. Myself, I would have pushed it until you sent a note to the pharmacy that said, Andrew, you're not going to have a prescription beyond this date, at which point, lo and behold, I'd find a phone, I'd be able to get in touch with you, and I'd show up for an appointment. And that's just that was just the way that I operated when I was using. So, but I don't see a problem with it. I think the benefits outweigh the risks.
Okay.
Yeah. I think it also depends. Like sometimes if I have a really long-standing relationship with somebody and I know that's not their usual pattern and something is going on, I might be more likely to keep extending it. If it's somebody who I've just met and I don't have that established relationship, I might extend it a couple of times and then say no. So I think there's a lot of different factors.
Yeah. And question in the chat, are you talking about extending for a week, extending for a month?
I usually just extend it to the next clinic, till the next time I'm in.
Yeah, which usually a week is what I would say. I mean, sometimes it's 2. You're right. There's kind of give and take around how often as a provider you're available. That has to be factored in also. I don't think I would extend someone for 3 months without having any contact or knowledge of what they're doing. I think, if I'm seeing them in a month and they miss that visit, then, a week and then maybe another week. And then, as Andrew said, I think if the message from the pharmacist is there's not going to be a prescription if you don't show up in some way, then there will typically be some kind of connection. Yeah. I know there are some other questions. Maybe we can sort of do a little post on the listserv that answers some of them that we can't turn the clock back or answer in 30 seconds now. But I'm hoping that based on the chat that we actually got to pretty much all of the questions that were related to these cases in this presentation. Thank you, everybody. Please fill out the evaluation form. Let us know what you would like more of in terms of webinars and discussions. Please join us for the November and December, and then we'll be shortly sending out our sort of proposed schedule for the new year, and we'll have more of everything. So thank you so much, Andrew and Anita, for sharing your expertise and your perspectives. And please, everyone, dig into that guidance document, use it, let us know how it's working for you. Remember that it's there to lean on. It's not there to be prescriptive or a recipe. And we hope that you find it useful.